Hello, and thank you for joining us today for this Contagion peer exchange panel discussion. Acute bacterial skin and skin structure infections, ABSSSI, have become a challenging medical problem often associated with high direct and indirect costs. These infections are responsible for an astounding more than 750,000 hospitalizations per year, representing a 17.3% increase in hospitalized ABSSSI patients from 2005 to 2011. If left untreated, these infections can cause potentially life-threatening infections in bones, joints, surgical wounds, bloodstream infections, heart valves, and lungs, to name just a few. This peer exchange panel of experts in infectious diseases is going to discuss the trends in ABSSSI incidence, cost considerations, and patient selection for outpatient parenteral antibiotic therapy. I'm Dr. Peter Salgo. I'm a professor of medicine and anesthesiology at Columbia University College of Physicians and Surgeons and an associate director of surgical intensive care at New York Presbyterian Hospital. Participating today on our distinguished panel are Dr. Yoav Golan, an attending physician at Tufts Medical Center in Boston, Massachusetts, and associate professor at Tufts University School of Medicine. Dr. Bruce Jones, infectious diseases clinical pharmacy specialist for St. Joseph's Candler Health System at Savannah, Georgia. All right, thank you so much for joining us. Thank you guys. Let's get right to the point. Let's discuss some basic, simple definitions. How do you define acute bacterial skin and skin structure infections?
Well, it's important to remember this is an FDA indication. That's when new antibiotics are being approved.
So you're telling me, first of all, it's a bureaucratic definition. But there's also a clinical definition too. So how do we go about this?
Well, so it's not what we use in everyday medicine. And it's actually, if you translate that to everyday medicine, it includes cellulitis or erysipelas, it includes abscesses, and it includes wound infections. This could be surgical wound infections, trauma-related wound infections, and so forth. And those three together make this FDA indication of ABSSSI.
But it wouldn't be a definition somewhere by some bureaucratic standard if there wasn't a number in it. And so do we have how big it is that needs to be, how big it needs to be to make that definition?
Absolutely. So what the FDA has established is that it needs to be greater than 75 centimeters, to be considered a major cutaneous abscess. So they want to know that it's of good size.
That's huge. 75 square centimeters is a lot of centimeters.
It's the size of a baseball.
The size of a baseball. Yes, that's a big infection. So just this once, I think we can all agree, you get 75 square centimeters involved, you've got a problem, whether it's cellulitis or erysipelas, wound infections, that's a big infection. So given that big infection, how big a problem is ABSSSI all told?
Yeah, I think it's this day and age, it's either the most common or one of the most common infections that we're seeing in inpatients that we deal with. In terms of emergency department visits, we're seeing over 3 million a year. Outpatient visits, over 14 million a year. So a big problem in today's society. Yeah.
Again, I come back to, I'm not sure I've ever really focused on it quite like that. That's a lot of infected tissue. And so we can lump that together into a big skin infection. That's a lot of people.
Absolutely.
Is that getting bigger? Is it a bigger problem than it used to be? You read about it in the paper sometimes.
Yeah, absolutely. I think we're seeing linear growth. If you look at the numbers now, every year we see more and more of these patients, and they're coming to physician offices, and where are they sending them? They're sending them to the emergency departments.
Mm-hmm. You hear the stories in the popular press. There's some kid who's a wrestler, he's a hockey player, he's a baseball player, and he comes in with some MRSA infection on his skin and loses an arm. Is that common?
Well, in the past, you actually needed to have risk factors, to have stuff and to have resistant stuff known as MRSA. Nowadays, everyone can develop those. And in fact, recent data from several studies in emergency departments show that MRSA is more prevalent than methicillin susceptible, which is susceptible version of this bacteria in the emergency department. So in the past, you needed to be a pro athlete and then just an athlete, and now you don't have to be an athlete at all. And those infections become very, very common in the community. As you know, particularly the MRSA version of staph has been particularly prevalent in ICUs many years ago, then in the wards, then in other institutions in the community, but now it's prevalent in the community itself.
So the gram-positive organisms that we typically see are what? They're staph and they're strep species. And you were talking about MRSA. It's always been my understanding that the resistance isn't the same as its virulence. That is, you can be resistant to antibacterials, but staph is staph. Is that fair?
Yeah, I would say so. And I think that there's no question, as we heard, that skin infections are increasing tremendously in the community, among community providers, in the emergency department, in the hospital, and other institutions. And I think that there are two main drivers to that, one or several drivers to that. And when you talk about the pathogen, what is interesting is that the stuff that we see circulating nowadays not only is more resistant to the common antibiotics that we use in the community, but actually it's a more virulent strain. In other words, it's a strain that's more capable of causing infection. There was a recent study that was done among military recruits showing that if you are colonized with this strain of staph as compared to other strains of staph before your preliminary or first training, you are far more likely to get infected during the training. And so this is a staph that's more capable of causing an infection, and an infection is harder to treat because the staph is more resistant to antibiotics.
Did I misspeak? I mean, I always thought that resistance is one thing, and then the virulence of the organism is another. But are you implying that there's a link between antibiotic resistance and virulence?
Yeah, I mean, I think that one way to look at antibiotic resistance is as a virulence factor, because the more resistant you are, the treatment options that we have are not as good, and the likelihood that you get early adequate therapy is reduced because there are fewer antibiotics that can be used reliably, and you are allowed to run the disease, and so the infection is going to be more severe at the end of the day.
So allow me to say that in my own defense, academically I might be right, but pragmatically I'm not. And what about, we've been talking about gram-positives, which, you know, when I was a medical student, it was always gram-positives in skin, but gram-negatives are out there too, right?
Absolutely. You know, I think if you look at specifically surgical site infections, certain surgical site infections, you know, as an example, if they include the GI tract, I think gram-negatives come into play. You know, we spoke earlier, if you look at certain wound infections especially, you know, if purulence is found, it leans more towards staph. If you have a quick-growing cellulitis, for example, many times streptococcal.